is Professor Jorge Cortes. Please welcome. We're very honored to have you here. Professor Cortes is the director of the Georgia Cancer Center in Augusta in the United States. And before joining the Georgia Cancer Center in 2019, he has been spending 23 years at the University of Texas MD Anderson Cancer Center in Houston. Most recently as professor of medicine and deputy chair at the Department of Leukemia, where he directed the CML and the AML program. Professor Cortes' clinical interest focuses on new drug development and the management of patients with CML, other leukemias, and myeloproliferative disorders. He led many of the most important CML clinical trials over the past decades and has authored nearly or potentially now over 1,000 peer-reviewed articles during his career. He is one of the 3 chairmen of the meeting, and we're very excited to hear your personal highlight, the clinical highlights of the meeting, Professor Cortes. The room is to you.
Thank you very much. Thank you all for joining, and it's my pleasure to give you this brief overview, which will probably not make justice to the excitement that we had at the meeting. I think it was a fantastic meeting. It always has been a great meeting since John Goldman started this, and of course, after 3 years of not being able to have it in person, it was great to see colleagues and be able to interact and network, which is one of the big highlights of the meeting for me. But we also had some outstanding presentations in many areas. I will start with some overview of one of the areas that was discussed. There was a lot of presentations on updates on some of the new drugs that are being developed or that had been recently developed or updated. There were some presentations on Asciminib. Some of them updates. Fabian Lang from Frankfurt presented an update on the role of Asciminib in patients with T315I. And we've heard about these very potent activity that we have with this drug, and certainly that was confirmed in these update. Very high levels of response. Interestingly, both in patients who have not been previously exposed to Ponatinib and in patients that have been exposed to Ponatinib, even those who have had resistance to Ponatinib, certainly the response rate goes down. But it is still a very high response level, suggesting the efficacy of this drug. There were other presentations on Asciminib. One of them, excuse me, was given by Andreas Hochhaus from Jena, who updated us on the results of the ASCEMBL study, this time with a 96-week update, and confirming that the superiority of Asciminib over Bosutinib is being maintained, not only now in major molecular responses, but also starting to see a very encouraging rate of MR4s and MR4.5s. And for those levels of response with this very heavily treated population, the numbers, as expected, are still low but growing, and it is very exciting to see that we are getting to those levels of response. There were also updates on Ponatinib, both in the effect of baseline mutations on the outcome in the OPTIC trial, and that shows that patients with T315I had the greatest benefit on the response rate compared to other patients when they received 45 milligrams as a starting dose compared to the lower doses, but also that there is a benefit for the patients that have other mutations or who have no mutations. So really all patients benefit, although certainly the largest differential in response in favor of the 45 milligram is those patients that have the that receive that have the T359 mutation. We also looked at an analysis that was presented by Gian Antonio Rosti of the PACE and the OPTIC trials, looking at the dynamics of the doses over time. If you remember, he reminded us that PACE used 45 milligrams throughout. OPTIC used the 45 milligrams with a dose reduction after response, and it showed how, as expected, much faster the dose intensity goes down in the OPTIC trial. And between these and the study that the update from the OPTIC trial, both analyses showed a decrease in the rate of arteriocclusive events, which was certainly very welcome for this patient population. So very nice updates in this setting. There was also a presentation, an update on the role of Vodobatinib, a new tyrosine kinase inhibitor. This one does not have activity against T359, but it did show a very significant levels of activity, both in patients. The main analysis was focused on the number of prior TKIs that the patients had received, both in patients that had received 2 TKIs or less, or patients that had received 3 TKIs or less, or who had received Ponatinib. The response rates were very high. The major cytogenetic response was in excess of 60%. There were major molecular responses and in more than 50% of the patients. And this was showing a very good toxicity profile. There were not really major adverse events that were described, no significant arteriocclusive events. So a very valuable potential new drug. This drug is still under development, not yet available in any country. One important part of this meeting was a section that we had on real-world data, which was very valuable because it showed some updates in settings that are less typical of the clinical trial. And so first, this was introduced very brilliantly, very elegantly by Dragan Milojevic, who put it in the context of what we can expect between the clinical trials and the real-world data. And then we had a couple of real-world experiences with Asciminib, one coming from the Netherlands and the other one from the UK, and this showed essentially the same efficacy that we had seen in the previous presentations. But importantly, because this population is much less selected, is a little bit more like the patients that we treat in the clinic, it was reassuring not only to see the efficacy of the drug, but also, very importantly, the safety of the drug, because they both highlighted that there were minimal arteriocclusive events, one of these events that, one of these toxicities that we worry the most about nowadays. And they showed very, very low levels of these, if at all. So certainly very encouraging data from these real-world experiences. There was a presentation that I enjoyed, perhaps just an early observation, something that needs to be discussed further. But Dennis Kim from Toronto showed the impact of a gene variant on a gene called HMG-CLL1 as a predictor, not only of the response of therapy, but also the progression with imatinib, but it impacts much less on patients who are treated with second-generation TKIs as initial therapy. It's not clearly understood what this gene codes for and why this difference between imatinib and the prognostic impact that it may have in patients treated with imatinib or second-generation TKI, but certainly something that deserves further investigation, and I'm sure we're going to be hearing about this in the future. As Daniela mentioned, there was a lot of discussion about TFR. So we had many presentations about these. Daniela already mentioned the significance of residual disease when we see the PCR, these low levels of PCR. Only those patients who carry these in myeloid cells are the ones who eventually relapse. That was part of that presentation by Ilaria Pagani, but there were also presentations focusing on other aspects. For example, we had the final report of a study from Toronto with a second attempt of TFR, and these showed a very low success rate in these patients with a second attempt. The big issue with the design of this study is that for the second attempt, patients had used Azatinib after they failed their first attempt with Imatinib, but they required a very short duration of a deep molecular response, and that taught us that certainly, particularly in that setting, you need longer duration of a deep molecular response. There was also a nice update by Frank Nicolini on the TFR after Nilotinib or Dasatinib as first line in chronic phase. This is from France, the series from France, showing very good results in this context. Certainly, by now we have expected that, but because the bulk of the data initially came from Imatinib, these long-term follow-up results from both Nilotinib and Dasatinib first line are very valuable. One major gap that we still have is we don't have much data on Bosutinib as first-line therapy and following with treatment discontinuation. Of course, we would expect the same, but it'll be nice to see some data. There was also a very nice study from Bologna on a 10 years experience with TFR, again showing the very good the very good results. And then there was a nice presentation on patient-reported outcomes from Dr. Cho and Degon, who showed the benefits in the patient-reported outcomes of the treatment discontinuation in these patients. So very nice presentations here. There was also some special sections. For example, we had a special symposium. This was in honor of our dear colleague and friend Michele Baccarani, who unfortunately passed away, and it's very unfortunate that he passed away the same year where Santa Tura also passed away, and then Dr. Hoffman, three people who worked together in many aspects, and we wanted to emphasize the collaborations that that Michele Baccarani was a big champion of, and we had some great presentations. Fausto Castagnetti gave us an update on what's going on with in Gimema. Simona Savrini gave a very nice review, outline of what they've been doing with the mutation assessment, and very particularly important is showing that she showed that these, by assessing mutations by next generation sequencing, we can find mutations early on when they may not be detectable yet by Sanger sequencing, and that may be important because these mutations, then these clones eventually result in resistance. So she showed some examples where that mutation was already present, but it was not detected initially. So highlighting the value of next generation sequencing as a tool. We don't use it routinely in the clinic today, but it's certainly very, very important. There was also a nice presentation by Sue Branford about the iCMLf Genomic Alliance, a very important activity organized by the iCMLf because we've learned more and more of the presence of these additional mutations and other molecular abnormalities, even from the time of diagnosis on patients who are eventually not going to do well. But because there are so many variables and combinations, etc., collecting data globally and large numbers becomes very important. So Sue is spearheading these and with the iCMLf and with Harmony to try to address these issues. Then we had an update from Francois Mahon on the final results of the Euroski, showing the high levels of success with treatment-free remission. This is important because it's the largest series that has ever been collected for treatment discontinuation, and it showed the benefit of this attempt. And finally, an interesting presentation by Ihab Atala on the last trial, the US CML consortium trial, focusing mostly on patient-reported outcomes after treatment discontinuation, and it highlighted that there was benefit in many of the parameters that were measured: fatigue, diarrhea, depression. Although it was modest by some measures, it met the criteria that they required, but it was modest in general. So very important to try to understand that there could be improvement, but also that some of these factors are multifactorial and they may not fully recover in the patients. Of course, there are many benefits for patients who discontinue therapy. I just want to highlight a couple of other things. We had a couple of debates. One, a beautiful debate that I really enjoyed, that was held between Daniela and Emil Shemionek from Aachen on whether intrinsic or extrinsic factors are more relevant for the persistence of the disease. Daniela argued of the role of the microenvironment, the immune factors, etc. Merely emphasized the fact that the leukemic cell by itself has already that propensity and may drive those factors in the microenvironment. It was beautifully done, and it showed how these two factors interact. Of course, the debate is fun, but it mostly highlighted the fact of the very tight interaction between these two elements. And then we had a clinical debate between myself and Delphine on the role of Ponatinib versus Asciminib for third-line therapy. And again, we both emphasized the benefits, the values of each one of the drugs that we were trying to defend. Ultimately, I think the vote was very close, reflecting the fact that it is an individual decision for each patient whether you use Ponatinib or Asciminib, two very good drugs that we welcome in our clinic. I just want to finish by highlighting one of our special lectures that was presented by one of our guest speakers, Joiti Nangalia from Cambridge. This was on the phylogenetic trees in hematopoiesis in myeloid malignancies. And she showed very elegantly how in myeloproliferative neoplasms, particularly those with JAK2 mutations, they can, by a very elegant work of, growing the clones of the cells and single cell analysis, etc., they identified that the mutation precedes the disease many years, sometimes very from the time of birth, before the clinical presentation is obvious, whereas in CML this is very short-lived. It's only a few years before the diagnosis that you see that the emergence of the mutation and then a rapid expansion of that clone because it grows so fast. So very different ways of the development of these two entities that we consider both myeloproliferative neoplasms, but those the originating molecular abnormalities have completely different roles. So, we could go on and on, but in summary, I think we can conclude that this was an outstanding meeting, lots of good presentations, very good posters that we don't have time to go through. I think we all came back energized of all the good research that's happening in CML and so many colleagues that are doing fantastic work all over the world. So thank you very much, and we'll be happy to take any questions.
Thank you so much, Jorge, for sharing your highlights, your clinical highlights from the conference with us. We have now time for a bit of questions, so please feel free to submit your questions via the chat. As a start, I'd like to ask both of you more general questions. So I think, Jorge, you have just mentioned that it was a very, very interesting meeting with lots of data, but I'd like to hear from you. What is your impression? Is there still much or enough research going on in CML? I remember someone saying that CML is quite a boring disease compared to other hematologic malignancies. What is your impressions just coming from the conference?
Well, if these, of course, I've always been biased towards CML, but if these conferences an indication, there's a whole lot of research going on and many questions that we still need to address. And if we're going to really cure this disease, we've made tremendous progress, no question, and we feel very satisfied with what we've done so far. But as you dig deeper, you also understand some of these questions. For example, all this issue of those molecular abnormalities that occur, sometimes from the time of diagnosis, their significance, why this happens, and then we haven't even started looking at how do we address these patients. That would probably need a completely different approach that the simple TKI single agent that we do for everybody without looking at these things. All these issues of the persistence of the leukemic stem cell, we are very satisfied with the fact that we can stop therapy in some patients, but it's only a minority, and we need to understand better what lets these earlier progenitors persist, so that we can look at better ways of eradicating them and make treatment-free remission a reality. There's new drugs being developed. There's a lot more we're understanding and learning about microRNAs and the role and the metabolomics, and that little by little are getting us closer. So yes, there's a whole lot of research still going on, and this meeting was incredibly exciting looking at all of these.
Great to hear. Daniela, do you agree on this opinion?
Yes, absolutely. I think, some people also said to me, it feels like you walk away with more questions from this conference than you had before you went there, just because it's such a stimulating discussion. And as Jorge also mentioned, there's still so many things we need to do. I think, yes, there's metabolomics, but it's also, that's inside of the leukemia cell, but what actually about the metabolome outside of the leukemia cells? I mean, there's a whole environment there where the metabolites very likely are also playing a role. And then there's all these questions of resistance. Why do some people respond so well, others do not? Why do some people progress to blast crisis and others do not? And that's, I think, still the discussion is ongoing. I think we do have to continue to remind funders that CML is a well-controlled disease, but we still have lots and lots of work to do. And just like in the past, I think our findings in CML will always also advance our understanding of other malignant diseases, but also normal hematopoiesis. So, please remind all your funders that we still need funding for CML research. I think that's a very, very important point.
Thanks for your opinion on this. There is one question coming through the chat. So can you please discuss current data concerning regaining of remission after loss of TFR, imatinib, or other TKIs?
Well, in many of the series that discuss these during this meeting, we learned that the overwhelming majority of patients who, if you're following them properly, if you're monitoring them closely as we're supposed to, and you detect that loss of response early on, then the overwhelming majority of patients do regain their response. During the keynote presentation on this at this meeting that Suzanne presented, she reminded us that there are an occasional patient who the relapse evolves to a blast phase. These have been fortunately extraordinarily rare. They're mostly anecdotal. So the overwhelming majority of patients regain the response. One of the questions to answer then is, what is the optimal setting then for a second attempt for treatment discontinuation? I described the presentation by Dr. Kim from Toronto, showing that if you try to do it too soon, the outcome is not going to be good. So we need to define that better. But certainly with proper monitoring, with proper follow-up, when you identify the loss of response, most patients will respond again to treatment.
Thank you so much. Any other questions from the audience? If not, we're coming to an end, and I'd like both of you to ask one question with view to future directions. So the conference is over, but we start to plan the next one right now. So what would be the main research, CML research areas that you'd like to see addressed at the next conference? What would be your personal wishes?
If I may start, I think what we should try and encourage again for next time is the immunological aspects. We had one talk this year, and I think immunology plays a very, very important role, especially in this whole question of treatment-free remission. And hopefully we'll be able to encourage some more abstracts and more talks on this topic. I think that would be very valuable.
And Jorge, what's your wish?
I agree. I think that's a very important topic. I'm also very much looking forward at additional research, both in terms of the incidence and prognostic implications of these molecular abnormalities that happen in addition to the BCR-ABL, but also what drives them, how they interact with each other, and then of course how we're going to manage them, how we're going to address these patients, because it is an important element that we hadn't recognized for a long time, but now it's very clear that it's present in many patients, and we need to do something more than what we've been doing. So I look forward to more research in that area.
Thank you so much. We are already a little bit ahead of time, but there's one final question coming through that I'd like to address this to you. Can you talk briefly about withdrawal syndrome and what causes it? I think. Well,
this is we know from the early days of the withdrawals of the discontinuation studies from Francois Mahon and his group, that this occurs in some patients. Some have reported as many as 30 to 40% of patients having withdrawal syndrome. Most of these are mild, and they resolve over time. Interestingly, I mentioned the PRO study from the last trial, the PRO arm of the last trial. And one of the symptoms that was very interesting is the pain. The pain actually increased after treatment discontinuation and then improved, perhaps reflecting that withdrawal syndrome. So it is very important to, number one, discuss with the patient before we stop, call it to their attention, communicate with them so that we can manage it. Most of these patients respond well to just an anti-inflammatory therapy, nothing major, and then improves over time. There are occasional patients, very few, but it can happen on some patients who just have to resume therapy because of the withdrawal syndrome. That again is rare, but certainly that is something to keep in mind when nothing else works.
Thank you so much for taking this question. Before we close, do you both have any final comments reflecting on the conference? Anything you'd like to share before we close?
I think once again, it became very apparent, especially as we hadn't seen each other for almost 3 years, what a very tightly knit community the CML community is. And I think, to me personally, just being involved and knowing really the leading figures of the CML community who was so involved and successful at, finding therapies and making CML a very controllable disease is fantastic and very, very rewarding and inspiring. And that is what's so special to me personally.
Well, my final words is to remind everybody of October 2023. We're going to meet again in Mandaloo. And I know many of you are doing great work in CML. This program comes from the abstracts that all our colleagues, researchers from all over the world, we had presentations from all over the world. And we want to continue hearing what everybody's doing to help us overcome the disease. And this, importantly, and this is part of the mission of the International CML Foundation, we need to address the problems that occur also in the parts of the world that have fewer resources and the creativity that our colleagues in many countries are having to try to help their patients overcome the disease. So we encourage everybody to stay tuned for the call for the abstracts and plan to attend to this meeting. It is an outstanding meeting, not just for the science and the data, but as Daniela emphasized, for the camaraderie, for the networking, for the collaborations that occur there as we're having a coffee, as we're discussing the posters, as we're just having a quiet time and during a break with a colleague or something like that. So please keep it in mind.
Thank you so much. So we're coming to an end. We're a bit ahead of time. It's now time to say thank you to you, Daniela, and to Jorge for your time, for your commitment, for making this possible, and especially for sharing your expertise. And thank you also to everybody who attended this call today and for submitting your questions.